Welcome to Pediatric Case Review. Today we'll be covering Guillain-Barré Syndrome in children, providing you with a comprehensive overview of this important neurological condition. This lecture is designed for pediatric residents and fellows seeking to understand the presentation, diagnosis, and management of this condition in the pediatric population. Let's consider this case. A previously healthy 6-year-old presents with progressive weakness in both legs for 3 days following a respiratory infection last week. What is the most likely initial symptom pattern in pediatric Guillain-Barré syndrome? Is it A, asymmetric upper limb weakness, B, symmetric ascending weakness, C, facial weakness preceding limb weakness, or D, sudden onset quadriplegia? The correct answer is B, symmetric ascending weakness. Guillain-Barré syndrome typically presents with symmetric weakness that begins in the lower extremities and ascends upward. Approximately 2/3 of pediatric cases follow an antecedent infection, usually respiratory or gastrointestinal, occurring 1 to 4 weeks before symptom onset. Children may also complain of paresthesias or pain in the extremities as early symptoms. Here we have a 7-year-old boy who developed bilateral leg weakness 2 days ago that has now progressed to involve his arms. When does Guillain-Barré syndrome typically reach its maximum severity? Is it A, within 24 hours, B, within 2 to 4 weeks, C, after 8 weeks, or D, progressively worsens over 6 months? The correct answer is B, within 2 to 4 weeks. Guillain-Barré syndrome typically progresses over days to weeks, with maximum severity reached within 2 to 4 weeks from symptom onset. This progression timeline is an important diagnostic feature that helps distinguish GBS from other acute neuropathies. If progression continues beyond 4 weeks, clinicians should consider alternative diagnoses such as chronic inflammatory demyelinating polyneuropathy. Let's examine this case. An 8-year-old presents with progressive bilateral weakness and numbness. On examination, which finding is most consistent with Guillain-Barré syndrome? Is it A, hyperactive deep tendon reflexes, B, preserved sensation with diminished strength, C, diminished or absent deep tendon reflexes, or D, pronounced cognitive impairment? The correct answer is C, diminished or absent deep tendon reflexes. Areflexia or hyperreflexia is a hallmark neurological finding in Guillain-Barré syndrome. Patients typically present with symmetric weakness in an ascending pattern while maintaining normal cognition, since GBS does not affect the brain. While sensory symptoms may be present, motor weakness with decreased reflexes is the predominant and most consistent feature. In this case, we have a 5-year-old with progressive weakness who shows heart rate fluctuations and blood pressure instability. Which autonomic manifestations are commonly seen in pediatric Guillain-Barré syndrome? Is it A, sustained hypotension only, B, sinus tachycardia only, C, blood pressure fluctuations and cardiac arrhythmias, or D, no autonomic involvement in children? The correct answer is C, blood pressure fluctuations and cardiac arrhythmias. Autonomic dysfunction affects approximately 20 to 70% of Guillain-Barré syndrome patients, including children. These manifestations can include tachycardia, bradycardia, hypertension, hypotension, and various cardiac arrhythmias. Severe autonomic instability may require continuous cardiac monitoring and is associated with more severe disease. Other autonomic manifestations may include urinary retention, ileus, and syndrome of inappropriate antidiuretic hormone secretion. Which of the following best describes the pathophysiologic mechanism of Guillain-Barré syndrome? Is it A, direct viral invasion of peripheral nerves, B, autoimmune response against peripheral nerve components, C, metabolic damage to myelin sheaths, or D, primary muscle inflammation affecting neuromuscular junction? The correct answer is B, autoimmune response against peripheral nerve components. Guillain-Barré syndrome is an immune-mediated disorder where antibodies and inflammatory cells attack peripheral nerves through molecular mimicry. Following infection, antibodies developed against pathogen antigens cross-react with gangliosides and other components of peripheral nerves. Different GBS variants exist, including demyelinating forms where the immune response targets myelin, and axonal forms where it directly damages nerve axons. In this case, a 6-year-old presents with progressive symmetric weakness and areflexia. Which test is most important for confirming the diagnosis of Guillain-Barré syndrome? Is it A, brain MRI, B, lumbar puncture, C, serum antiganglioside antibodies, or D, electromyography and nerve conduction studies? The correct answer is D, electromyography and nerve conduction studies. EMG and nerve conduction studies are the most specific test for confirming Guillain-Barré syndrome, showing slowed conduction velocities, conduction blocks, or temporal dispersion depending on the subtype. Lumbar puncture is also important, typically revealing albuminocytologic dissociation with elevated protein but normal cell count. However, CSF protein may be normal early in the disease course. The diagnosis is established by combining clinical presentation with supportive EMG and CSF findings. A lumbar puncture is performed on a child with suspected Guillain-Barré syndrome 1 week after symptom onset. Which cerebrospinal fluid finding is most consistent with this diagnosis? Is it A, elevated protein with normal cell count, B, normal protein with pleocytosis, C, elevated protein and elevated cell count, or D, normal protein and normal cell count? The correct answer is A, elevated protein with normal cell count. This finding, known as albuminocytologic dissociation, is characteristic of Guillain-Barré syndrome. It's important to note that cerebrospinal fluid protein may be normal in the first week of symptoms, with protein elevation typically becoming evident by the second week and peaking at 4 to 6 weeks. If significant pleocytosis is present, more than 50 cells per microliter, clinicians should consider alternative diagnoses such as infectious causes or malignancies. Let's discuss this case. A 7-year-old with confirmed Guillain-Barré syndrome has progressing weakness affecting ambulation. Which treatment should be initiated first? Is it A, oral corticosteroids, B, intravenous immunoglobulin, C, plasma exchange, or D, supportive care only? The correct answer is B, intravenous immunoglobulin. IV at a dose of 2 grams per kilogram divided over 2 to 5 days is the first-line immunotherapy for pediatric Guillain-Barré syndrome with significant weakness. IV is most effective when administered within 2 weeks of symptom onset. Plasma exchange is an alternative with similar efficacy, but is logistically more challenging in children. Notably, corticosteroids have not shown benefit in GBS and may actually worsen outcomes, so they are not recommended. In this case, an 8-year-old with Guillain-Barré syndrome develops rapid, shallow breathing and decreasing vital capacity. What respiratory parameter best predicts the need for mechanical ventilation? Is it A, respiratory rate greater than 30 breaths per minute, B, vital capacity less than 20 milliliters per kilogram, C, partial pressure of arterial oxygen less than 70 millimeters of mercury, or D, oxygen saturation less than 92%? The correct answer is B, vital capacity less than 20 milliliters per kilogram. This parameter is a strong predictor for impending ventilatory failure in Guillain-Barré syndrome. Approximately 15 to 20% of pediatric GBS cases require mechanical ventilation. Other important indicators include rapidly declining vital capacity, bulbar weakness affecting airway protection, and signs of respiratory muscle fatigue. Children with concerning respiratory parameters should be admitted to the pediatric intensive care unit for close monitoring and potential intubation before an emergent situation develops. A 9-year-old with severe Guillain-Barré syndrome requires intensive care unit admission. Which acute complication requires immediate intervention? Is it A, syndrome of inappropriate antidiuretic hormone secretion, B, constipation, C, autonomic instability causing cardiac arrhythmias, or D, depression? The correct answer is C, autonomic instability causing cardiac arrhythmias. Cardiovascular autonomic dysfunction can produce potentially life-threatening arrhythmias requiring immediate intervention. Continuous cardiac monitoring is essential for severe Guillain-Barré syndrome cases, and antiarrhythmic medications may be necessary. While the other complications listed are important to address, including syndrome of inappropriate antidiuretic hormone secretion, constipation, and psychological impacts, they generally present less immediate danger than significant cardiac arrhythmias, which can be fatal if not promptly treated. Parents of a child with Guillain-Barré syndrome ask about long-term prognosis. What is the most accurate information regarding pediatric GBS outcomes? Is it A, complete recovery in greater than 90% of cases, B, complete recovery in 50 to 70% of cases, C, most children have permanent motor deficits, or D, recovery depends on early corticosteroid administration? The correct answer is A, complete recovery in greater than 90% of cases. Children with Guillain-Barré syndrome generally have an excellent prognosis compared to adults. Recovery typically begins within 2 to 4 weeks after symptoms plateau, although full recovery may take several months to a year. Approximately 5 to 10% of children may experience some residual weakness or sensory changes. Factors associated with poorer outcomes include need for mechanical ventilation, rapid progression of symptoms, and axonal forms of the disease. A child presents with ophthalmoplegia, ataxia, and areflexia. Which Guillain-Barré syndrome variant is most likely? Is it A, acute motor axonal neuropathy, B, Miller-Fisher syndrome, C, acute motor and sensory axonal neuropathy, or D, acute inflammatory demyelinating polyneuropathy? The correct answer is B, Miller-Fisher syndrome. This GBS variant is characterized by the classic triad of ophthalmoplegia, eye muscle weakness, ataxia, coordination problems, and areflexia, absent reflexes. Miller-Fisher syndrome is associated with anti-GQ1b antibodies and typically has a better prognosis than classic GBS forms. It accounts for approximately 5 to 10% of Guillain-Barré syndrome cases in children. Other variants include acute motor axonal neuropathy, which affects only motor nerves, acute motor and sensory axonal neuropathy, which affects both, and acute inflammatory demyelinating polyneuropathy, which is the most common form. A 6-year-old presents with symmetric weakness and areflexia, but has persistent fever and markedly elevated cerebrospinal fluid white blood cells. Which condition should be suspected? Is it A, transverse myelitis, B, myasthenia gravis, C, acute flaccid myelitis, or D, enterovirus-associated meningoencephalitis? The correct answer is D, enterovirus-associated meningoencephalitis. The persistent fever and markedly elevated cerebrospinal fluid white cell count are not typical features of Guillain-Barré syndrome, which classically shows normal cell count. Enterovirus infections can cause meningoencephalitis with associated weakness that may mimic GBS. Other important differential diagnoses include acute flaccid myelitis, which typically shows spinal cord gray matter lesions on MRI, spinal cord compression, myasthenia gravis, which affects the neuromuscular junction, and tic paralysis, which improves after tic removal. A child with Guillain-Barré syndrome has been bedridden for 1 week. Which nursing intervention is most important to prevent complications? Is it A, daily chest physiotherapy, B, positioning changes every 2 hours, C, passive range of motion exercises twice daily, or D, all of the above? The correct answer is D, all of the above. Comprehensive care for a bedridden child with Guillain-Barré syndrome requires multiple interventions. Positioning changes every 2 hours prevent pressure ulcers. Daily chest physiotherapy helps prevent atelectasis and pneumonia, which are significant risks due to impaired cough and possible respiratory muscle weakness. Passive range of motion exercises prevent contractures and maintain joint mobility. Early involvement of physical and occupational therapy is also crucial for optimal recovery and should begin as soon as the patient is medically stable. Which feature of Guillain-Barré syndrome is more common in children compared to adults? Is it A, facial nerve involvement, B, need for mechanical ventilation, C, complete recovery, or D, axonal forms in North America? The correct answer is C, complete recovery. Children with Guillain-Barré syndrome generally have better recovery rates than adults, with more than 90% achieving complete recovery compared to 70 to 80% of adults. Facial weakness is common in both pediatric and adult populations. The need for mechanical ventilation is similar between age groups at approximately 15 to 20%. Axonal forms of GBS are more common in certain geographic regions like Asia regardless of age, rather than being specifically more common in either children or adults in North America. Parents of a child recovering from Guillain-Barré syndrome ask about recurrence risk. What is the approximate recurrence rate for pediatric GBS? Is it A, less than 2%, B, 5 to 10%, C, 15 to 20%, or D, greater than 25%? The correct answer is A, less than 2%. Recurrence of Guillain-Barré syndrome is rare, occurring in approximately 1 to 3% of cases. Some apparent recurrences may actually represent chronic inflammatory demyelinating polyneuropathy that was initially misdiagnosed as GBS. Families can be reassured that specific precautions to prevent recurrence are not necessary, as triggers are often common infections that cannot be reasonably avoided. There is also no known specific genetic predisposition that would impact family planning discussions. Thank you for joining this comprehensive review of Guillain-Barré syndrome in children. Remember that early recognition and intervention are critical for optimal outcomes, though children generally have an excellent prognosis. We've covered the clinical presentation, examination findings, pathophysiology, investigations, treatment, and complications of this important neurological condition. Please subscribe to Pediatric Case Review for more educational content on pediatric conditions. If you have any questions, feel free to leave them in the comments section below, and we'll address them in future videos. Until next time, thank you for watching.